Well, welcome. We've had a lot of shows, a lot of fun talking about different topics, and really how lucky we are to have the medical services and the quality of medical personnel we have here at the center of the universe. And we thought tonight, let's take some time and talk to the two people who are instrumental behind getting these services to Milford. And let's get their perspective on, one, how they did it and took the little red hospital that tried to the medical center that does, and what's in the future. So why don't we start with introductions?
Hi, Al. Ed Kelly. I'm Milford Regional President and Chief Executive Officer.
Hi, Al. Phil Ciarmacoli. I'm President of Tri-County Medical Associates, and Tri-County Medical is a subsidiary of the Milford Regional Medical
And that's
Center.
one of the best kept secrets, is that I don't think people understand, the three legs of the medical center.
Yeah, and I'm glad you mentioned it because we are an integrated system. It started, and I've said this in the past, it really, Ed and Frank back in 1992, there was a need for primary care docs in the Milford community. Docs at that point in time did not want to go out and borrow money and sign a 5-year lease, hire staff. So we formed the employment model. So the Tri-County is really the employment model to attract primary care physicians. And yes, it is a subsidiary of the hospital, and we are one integrated unit. And I'll just leave it at that for now, and I'll give it a chance to Ed to say something.
Liking Phil's wife, and Gail coming to you saying, my husband needs employment, would you please give him a job? But there's got to be a better reason that you as the CEO support Tri-County.
Sure. Just a little bit of history, Al. Just as I was coming to Milford, Tri-County, as Phil said, was established. It was really the beginning of the trend. Prior to that, physicians got out of training and they went into business for themselves. So they had to set up, they had to go out and take a loan, find an office, rent it. It was, in some cases, more of learning the business than practicing medicine. And they got good at it, but over time, there was a change, so physicians wanted to practice medicine, and we couldn't get physicians to come to town to basically open up their own business. So for us, it was really a necessity that we went out and employed physicians, established the corporation. And we felt really lucky because we had residents established at Milford in 1991. And in fact, it was really their response. The first year the residents came to Milford, they said, we love Milford, but we don't want to go out and open our own business. We want to be employed. So none of the residents stayed that year. So we learned from that experience, set up the company. Then the next year, basically we were able to employ not only a bunch of them, but really the top of the graduating class. So it was very exciting for Milford, and really a turnaround in terms of why Milford was growing.
I mean, you think about it, friends of mine, Phil went to Holy Cross, I went to Holy Cross, a lot of pre-med students. And you talk to them and they'll tell you that, let's see, Holy Cross is $250,000, medical school isn't any cheaper. And then they come out, 4, 7, 9 years later, and they've got to go buy a home to convert into an office, put $200,000-$300,000 of equipment in, and they're sitting there saying, I'm $800,000 in debt before I've seen my first patient.
Right.
No wonder nobody wanted to go into primary care.
Yeah.
Right.
Yeah, I mean, there's still, you mentioned primary care, Al. There's still a huge shortage in primary care. And it's, today, there's a lot more expected of the primary care physician. Back in 07, we've been on the EMR since 08, but back in 07, I mean, you had paper charts, you were not automated. In 08, we went on electronic medical record, we were on GE Centricity, which in terms of documentation and quality is very good, but it takes time away from the visit, because rather than looking at the patient, you're looking at a tablet. So then comes meaningful use, which is Medicare, CMS requirements, then comes patient-centered medical home, then comes, ICD-10, which is new diagnosis codes, which I'm sure you're familiar with. So, I mean, there's just a lot that's brought to bear. And so, one of the things that Ed and I focus on is really recruiting. We need quality providers, and providers drive our system. Not completely. Obviously, we have technology, nursing, administration, support staff, but we really need our providers. So that's one of our main priorities. And people there is a shortage. I mean, we had a meeting with UMass, and they have a residency program, and we said, what do you do in internal medicine? How many residents? They have a class of 28. I said, how many residents go into primary care? So they got back to us, they gave us stats. Of the 28 residents, 6 went into primary care. And of the 6, probably 3 went to other states other than Massachusetts. Right. So you have, a leading medical and residency program in Central Mass graduating.
So you're fighting to get your share of the 3
residents. So, that is difficult, and, that's one of the concerns for us as a system. I mean, we've done well for years. That goes back to 1992 with Ed and Frank and building that primary care base, and that has been key, and we want to continue to build on that base.
But what's impressive is what the two of you have done. Right, wrong, or indifferent, they've got to like it, because the attrition rate, we don't lose a lot of docs once they're in your system.
Yeah. Right.
So whether we say, Ed, you and Phil did a great job or a terrible job, they're the ones that really are the judges. Because if they didn't like the environment you were setting up, you would not only be fighting for one of the 3, you'd have to replace 2 or 3 that you'd lose.
Right.
Yeah.
That's correct. I just want to add one other point, just to show the impact of what Tri-County meant. But when I came to Milford in January of '93, and the payers have consolidated, but at the time, Harvard was separate from Pilgrim. We didn't have a Harvard contract. We did not, so Harvard Community Health Plan, and that was the biggest plan at the time. We did not have an HMO Blue contract, and we did not have a Tufts contract. There was Pilgrim and Central Mass and United and a few others, but we did not have those. And that's because we really lacked a primary care base. And so the impact of starting Tri-County, bringing in primary care physicians, is suddenly the payers had to have us, and it gave great coverage to the community. So
I think Phil's left 2 or 3 primary care physicians not as Tri-County in this area. There's got to be 2 or 3 of them, because it seems like everybody else is.
It's a very, very small minority.
Yeah.
That's
the other credit, honestly, when we were starting, and it really goes to the heart of our medical staff, is they realized that to have a healthcare system here that was going to be effective, it needed to grow. And they realized it wasn't going to grow privately. And so it is quite, it speaks to the character of our medical staff at the time, that they would effectively welcome in competition, and welcome in competition employed by the hospital. And so that was a very delicate, cooperative, open relationship, and so it's really paid long-term dividends.
I mean, you look at other industries like the airline industry, they have a feeder system. They've realized that they're going to make their money and survive on their core flights or core activities. Isn't the primary care system a feeder for everything else in the medical center?
Sure, it's a feeder to medical and surgical specialists. It's a feeder for ancillary testing. It's a feeder to the hospital. It's a huge, huge feeder. That's why systems that have done very well have done that with a strong integrated primary care base. Plus, it's not just primary care. If you're looking to attract specialists, so you're looking to attract a cardiologist or a pulmonologist or a general surgeon or an obstetrician, having a built-in primary care base that they can get referrals from is very attractive for a specialist to come out into our system. So they really kind of go hand in hand. But it's really been a very successful formula, really.
Well, I mean, you think about it. I think of my mom when Dr. Farouk, who took care of her for many decades, and again, these names that have been around forever, to me, really show a testament of the environment management set up. He referred her to, when she had intestinal cancer, to Mona Cadis. No, Dr. Cadis. To my mother, it's Dr. Mona. But it was automatic. At that point, you're going through a shock. But when you have the fellow or the woman who's been taking care of you for decades saying, this is the right person to go to, there was no question that we were going to go out of district we weren't going to leave the Milford Medical Center area because, one, you want to stay, but two, your primary care is telling you that's
where
a
you
good
go.
decision.
Sure. Yeah.
Yeah.
But now, how do you get people to be primary? I mean, let's face it, cardiologists, you got all the sexy jobs that bring the best compensation.
Yeah.
But yet, the primary care, I mean, that's your foundation.
Yeah.
How do you get people to go into primary care?
You really have to like the continuity of care that primary care provides, because you have a patient, you see that patient on a regular basis, you develop a clinical relationship with that patient, you help that patient, whether it's all kinds of illnesses and diseases. That's really the attraction, versus more of a procedural driven kind of. The specialists are procedurally driven.
Yeah, you hope you don't have to see a cardiac surgeon too often.
Yeah.
Right.
So that's the
You need exposure to it. So if you get exposure to it, you do some training in it. Maybe you have a mentor physician that you connect with, and you say, that's who I want to be like. One of the interesting trends that we're starting to see in healthcare now is scribes. And so, for example, they're heavily used by a lot of physicians in our emergency department, and that's a group decision. The physicians in the group decide whether they want to scribe or don't want to scribe. And these are really smart people, actually doctors of the future. Often when I talk to them, they're applying to medical school. And it's a great experience for them. They're doctors in that particular case that are exposed to the emergency department. They're either going to love it or hate it. And so many, actually there was, our ER group last year, they contracted with a private group, and they predominantly used 7 scribes. All 7 of them got into medical school. So they learned, and they either like ED or not.
Right.
One of them said, I love giving good care, I love being involved in learning it, but they missed that continuity. They don't see that patient again. So they had this issue, they diagnosed it, they sent the patient off, and then they don't know what happened. Where, if you're exposed to primary care and you see that full cycle where you diagnose someone, you send them to a specialist, they get treatment, they come back, you see that loop closed. But as Phil says, it's a tough business because of all of the IT and everything else.
If they don't go with somebody like Tricon, I could see why. If I'm going to be a primary care physician, it's because I have a passion for exactly what you're saying. If I've got to deal with all the Medicare, Medicaid forms and all the documentation, you're just taking away from what I love doing, which is being with patients.
Well, that's the big frustration now, that physicians want to see patients. They want to practice medicine. And you have all of this other, what I'd call stuff, which is important. You got quality and you got documentation, but it does take away patient time. So how do you solve that problem? We're investing in a couple of different programs. We're investing, we're recently talking about bringing in social workers, okay, into the sites, because there's a lot of care coordination required. How do you get a hold of this specialist? How do you get a hold of this psychiatrist? How do you get into this hospital? How do you get into the ED? How do you get into wherever, okay? And that takes up a tremendous amount of time, because access, as we're talking about, access is very limited. So, where do you go? So we're thinking, I think we're pretty much at the point where we're going to implement bringing social workers into our sites. We also have, RNs. We have 4 RNs, within Tri-County, that we've identified high-risk patients who need more proactive kind of care, more follow-up care, more individual. We may go to the home, we contact them for appointments, we may provide transportation, we may do a lot of things to help them get to see their physician and to ensure that they're compliant. We have what is called population health coordinators that actually, because we have diabetic patients and we have hypertensive patients and we have asthma patients, and we want to see those patients. So we want to make sure that we follow up with those patients. So we'll have the population health coordinators actually look at a diabetic list of Dr. Jones and say, okay, Ms. Smith is due to come in 2 months, or Ms. Smith, we have to call to get her to come in. So we'll have these population health coordinators actually call the patient, schedule the appointment, and order the test.
So you're doing that on a local level?
Yes, yeah.
Because I've seen programs put in by the insurance companies.
Yeah.
So you've got Tufts that has that because they found if you can get better compliance, long term, the costs are much lower.
Yeah, that's the whole point. The point of everything we do in terms of patient-centered medical home, quality measures, RN care coordination, whatever we do is all based on the more that you interact and communicate with a patient, the lower the cost is going to be. And that's kind of the end goal, because our healthcare system, the costs just can't continue to go endlessly.
Well, I mean, I've always objected to the term medical inflation. And to me, it's just a rationalization.
Yeah.
You know, we've got to get better at providing core services. And, you know, I mean, I'm amazed when I see what the medical records, the electronic medical record system you put in, that's amazing to me.
Yeah.
You know, when I needed surgery in Virginia, I went and got it. When I came up to Milford 20 years ago, I had surgery to remove a cyst. I had to call, it was like 30 years ago. I had to call the office, and they kept those records, and they made copies.
Yeah. Yeah.
Can you imagine
That's labor intensive.
how much effort and resource it took to have somebody go dig out records from surgeries done 30-some years ago?
Yeah.
You do it with a flick of a button.
Yeah. I think we're going to be converting to Epic in about a year and a half. So I actually dread that conversion because it's a lot of work to convert even system to system. I mean, years ago we did it from paper to digital. Now we're going digital to digital, but it's still a lot of work to do the conversion. So that's another.
But it brings another level of service to the patients.
Yes, but my point is it just puts more pressure on the primary care docs.
Oh, God, yeah.
Okay, because now we get another transference of data. So anyway.
So, Ed, biggest challenge you see coming?
Right now, we're really trying to catch our breath. We've just occupied the new building. You know, anytime we've had projects before, there's a little bit of growing pain of moving into the building, learning it. There's startup costs. So, with regards to the new building, that's what we're doing. We haven't quite opened all the beds, and so, but it's going really, really well. Again, it's a bit of a detail, but we were able to move our new ICU and new ED departments in. We actually moved a nursing unit into what we call MP1. But really, one of the most exciting parts of our project was to move our old fourth floor adult patients into what's now called the consigli floor. And it's almost all private rooms. So we're getting very close now to almost all private rooms in the hospital.
No more of those four bangers?
Not four. We've got some on our fifth floor. On our fifth floor, we still have some semi-privates.
Yeah.
But we're working. We still have that goal to go with more private.
Remember, they had to keep the Portuguese patients apart, because if you tried putting 2 or 3 of them in the same room, each of them came with about 8 or 10 visitors all night. You never could fit them. So we always joke saying, you always have one Portuguese person amongst everybody else, because the nurses gave up. It was amazing, all the rules.
Yeah.
You know, when we were growing up, they had those little cards.
Yep.
And they had 2 cards. So guaranteed you only had 2 visitors. Yeah, well, the Portuguese women always left the door open in the back. And the next thing you know, the room is flooded with all these Portuguese grandmothers.
Yeah.
I remember one time, I always tell the story because I'm there, and the poor floor nurse came in and said, "Excuse me, you can't have 8 or 10 people in this room." Everybody, including my sainted mother here, no speaking English. Now, they'd been here 40 years, and all of a sudden, and I'd look at them, and in Portuguese they say, "You tell on us, we will hurt you." So, it was like 4 people in a room, and now we're trying to get from 2 people in a room to 1.
Right.
Yeah.
Yeah.
But it's got to be so much nicer.
It is. So it's incredible. If you walk back to the old emergency department or old ICU, you say, how did we do it? And again, it was really just a credit to the staff in terms of making that happen. So we're also starting to think now about what do we do with those vacated spaces, and it's likely a no-brainer on the 4th floor, because we anticipate growth, to go back and renovate that area and make them private. But we're going through a formal process. It's always so important to get medical staff input and to prioritize, and to have a good process where not only is it going to be important to say we're going to do these 3 and 4 things, but just that we have a fair and process to say, hey, we're not going to do these 15 things, or not yet anyway. So that's in terms of the hospital, what's on our horizon. So,
Did you ever think, when it was young Ed Kelly, the new CFO, that you'd be putting in a $50+ million addition?
no way. It was just, when I came in '93, it was a struggle. Again, it had the same feel in terms of camaraderie and a great medical staff and board. We all kind of worked together. But frankly, hospitals have been closing and really struggling. In the '90s, Newton Wellesley threw in the towel and said, we can't make it on our own. And we said, how much longer do we have? But it really comes back to take good care of patients, and the rest works its way
We
out.
used to have Whitensville.
Yeah.
Yeah.
What was it? The Milford Whitensville Regional
Regional
Hospital.
Hospital, yeah.
That's right.
Yeah.
And you sit there and say, okay, what were the odds that Milford Hospital was going to become this medical center?
Right.
Yeah. The community, Al, has been very supportive. As Ed mentioned, we did a $60 million addition. And, through philanthropy, we raised $25 million, for the little town of Milford.
Right.
We actually have done really very well. The community's been very supportive. I think that's what really contributes to the success of our
But
system.
you think about it, Phil, when we were kids,
Yeah.
you had 4 primary care. We always joke
Yeah.
that you can trace people's lineage by who brought them in the world. Was it Cicchetti, Capisi, Mastriani? You go down, there was only 4 choices.
Yeah.
But, okay, if you didn't feel good, you went to Milford. If
Yeah.
there was something more serious than a Band-Aid, you automatically thought of Framingham, Leonard Morse, or in town.
Yeah.
I don't think people worry anymore. When you look at the quality of care you've brought here,
Right.
Yeah. Yeah, I don't, yes, I think we've been hugely successful, and we're going to continue to grow. I think, Ed's philosophy and my philosophy and Frank's philosophy before us was really just to keep on building, developing, growing. We didn't really sit back and get complacent and kind of let the world go by us. We kind of said, hey, we're going to stay ahead of it. We're going to keep, growing and adding services and building buildings and adding facilities. And, that's worked for us.
but everything I read, Partners is scooping up hospital or center after center, and it's not because they're so profitable that they can stand on their own. Now you've got Partners being told, back off. You can't keep buying everything. What? Why did Milford work? You did something different from
Yeah. Well,
everybody else.
We listened to our medical staff. That was really, really important. The role of a community hospital is really important. And I just said this week at our annual meeting, it's really important that patients get care in the right setting. If they don't belong in the emergency department, they should go to the physician's office. If they shouldn't be in the hospital, then they should get treatment on an outpatient. But a big part of really overspending in healthcare is patients, and we're all guilty of this, going to the big centers when they can come to a community hospital. So they have to have faith in the community hospital. But it's often 3, 4, 5 times more expensive to have your gallbladder out in one of these big places. Yet there's not really a big penalty to individual patients for that. So if there's no price incentive to do that, then they still travel. So really, healthcare reform is still evolving. And I think because of our medical staff and in the community and really the whole team, I think you have to place it on the whole team. Our community's been growing, the area's been growing, our capture's been growing. So we've had this just kind of steady growth over, if you could look back over a couple of decades. And it hasn't been rocket scientist or a brilliant idea. It's been really doing the basics well. That was Frank's line. And it's just, one thing at a time.
But now we describe what you've built as our community hospital.
Yeah.
Yet the level of service, except for research, and I guess teaching, the level of service seems to be on par with anything I'm going to get, unless you have a real, if I have a very, very esoteric indication. Yes, children's hospital is always going to have their niche. But community hospital, what does that really mean when you look at, I got Dana-Farber right here, I've got all these places to choose from.
Well, again, that was the whole team, our medical staff, saying these type of services need to be provided in the community. So radiation therapy, if you need to go get treatment every day for 30 days, it makes so much sense to come to the community. So part of that was, in my opinion, these tertiary centers seeing the gem in Milford and saying we want to be there. And as Phil mentioned it, if they look out here and they see good primary care, they see good specialists, they see good ancillaries, they see, the patient takes the chart and the x-rays and their medical record into these places, and people say, wow, this is impressive.
Yeah.
This is impressive. So they want to do business with us.
I just think of you can't downplay the psychological effect of a patient. That, if they feel better, if they're not as nervous, they tend to do better.
Right.
When my mother was going through intestinal cancer, driving to the Milford Hospital, that it's home.
Yeah.
I gotta believe it helped her, versus if I had to schlep her in, fight the traffic, go into Boston.
Right.
And then not every family can afford to take off afternoon after afternoon to drive them in. So there's gotta be a huge quality of health care benefit.
Absolutely. I mean, we offer really, just, exceptional service for this community and in area communities. So it's I've often said to people, I don't mean to brag about our system, but sometimes I think people don't realize, what a system we have right here in Milford that services all these towns. I mean, it's really a credit to a lot of people. And as Ed mentioned, team's a big word. We really listen to our community, we listen to our board, we listen to our medical staff. We build consensus.
It was funny, a year ago I was out in a little place called the Mayo Clinic, and we were joking with a couple of their chiefs. I said, one thing I really love about this place is the pride that I feel your physicians take in being part of the Mayo system. And I joked, I said, almost as strong as Milford.
Did you say that?
I did. I did.
And they said, yeah, we knew that. Did they say, yeah, we knew that?
We got into this whole discussion. At the end, I actually got a tie that says Mayo Clinic that they gave me.
Did you say, not as good as Milford?
Yeah, I said, I got to see if there's a Milford tie.
Yeah, okay.
Where do you go from here now? I mean, we just did a huge addition.
Yeah.
You've brought the Farber in. I mean, it's amazing. You think of a Da Vinci robot in Milford.
Yeah.
I'm sorry, a million or 2 million?
Couple million.
A couple $1 million. Yeah, you would have bought Milford. They would have thrown in Hopedale, Mendon, and a couple towns early on.
Yeah.
It's pretty amazing that we're able to invest and maintain that level. Where do you go from here?
It's sort of brick by brick. It's what's the latest and greatest. So one of the things about the new building that people probably don't realize is, so we have to bring in new services, new ICU, new ED. We're always looking to make all the systems talk to as much as they can. So when you go out and you outfit those new units, it's like your phone. You might have a level 5, now you need 6, right? So from nurse call systems to telemetry across the board, we said, are we going to buy what we have and everyone's on the same, or are we going to upgrade? So there's a lot to do in terms of upgrading the rest of the hospital. We're working on that right now. So we bought the latest and greatest for the new building, and now we're going back and standardize it in the hospital. We bought a new CAT scanner for the emergency department.
Again, one of those low budget items.
Right, the latest and greatest. And so one of the new things out now is a feature, and again, we're administrators, iDose. So it's basically a program that minimizes radiation exposure. Well, all of our units got to have that now. So we've just upgraded all of our CAT scans. We've just, we're in the process, we have 2 MRI units, one at the cancer center and one at the main hospital. You may see a trailer out there. So we brought a trailer in, we took one of the fixed ones down, and we put in a new 3T system. We don't know what that is, but it's the latest and greatest in terms of MRI. It's constant. You don't do something once. And just starting this coming weekend, we're going to be taking down the one at the main hospital, and we got the mobile unit, so we always have 2 MRI units going. It's stuff like that. Phil's working at a new project in Hopkinton. You want to?
Yeah, I mean, we have, you know, we're always trying to update our outpatient facilities. So, you know, in Hopkinton, you know, we're building a new facility. It's not our facility, but we're taking some 6,000 square feet of space in Hopkinton, right on Lumber Street. It's right behind that existing strip mall. It's a brand new facility.
It's right across from the mobile station.
Yeah, it's right near, yes.
That's what people know Hopkinton is, the mobile and the Gulf that you get on the 495.
Right across from where the Golden Spoon used to be.
Yeah, but the Golden Spoon now is gone. It's
well,
a
actually,
Starbucks.
it's going to be in this new facility. It's going to
Oh,
be
is
a
it
new
right?
building. Yes, yes. I was told to promote the Golden Spoon tonight.
But somehow the greasy spoon disappearing just didn't.
But so we're taking, you know, 6,000 square feet there, and you know, we're going to have a MedPeds, which is a practice of board-certified internal medicine and board-certified pediatricians, which is new for us. In our sites, we either have family medicine docs, we have internal medicine docs, or we have pediatricians. This is, you know, individuals who are double-boarded. It's, you know, we feel as though we can recruit to this specialty. There's not many systems that have what I call, again, med-peds sites. So we feel like we have a little advantage. We have 2 med-peds physicians that have already started, and that not in that facility because that's under construction, but right in the building adjacent to it. We're also going to have urgent care on that site, which is our first entree into urgent care. So we're going to have.
Explain to me, Lucy, what urgent care means. If I'm sick, everything's urgent.
Well, you know, yes, that you kind of said it really, Al, because, you know, people are very much driven by convenience today. And, you know, you call, you know, physicians are busy, practices are busy. And, you know, people want to be treated when they want to be treated. So, you know, we can't even schedule, even if we had, you know, said, hey, we're going to have all morning open for, you know, urgent care type appointments in our primary care sites, someone at 2 o'clock will say, I want to go now, or I want to go, you know. So we're doing urgent care. We think it's really kind of something as a system. You know, we need, it completes our.
Will that take some of the burden off the ER?
Yes.
Yes,
Yeah.
that'll take some of the burden off the ER.
And again, that can be a good thing because we don't want business in the ED that doesn't belong there.
Yeah.
Right.
Yeah.
You know, we want them in a physician's office, or urgent care is a good alternative.
Sounds like a good intermediary because the insurance companies now are giving you a hint that they don't want you showing up with the sniffles to the emergency room because it's like a $250 or $500 deductible.
Well, it's a very significant copay too. I mean, the copay is
That's what I'm
very,
saying.
yeah. And so in urgent care, we're going to have radiology. We're going to have lab, so you're going to get x-rays. You know, we'll be open 7 days a week, so you have weekend access. We're very excited about the program. It's something, again, I think we really
so you're
need.
really looking at, this is a mini emergency department.
I don't know if I'd quite say that.
I hear you. Jeff Hopkins will kick me when he sees me.
I don't know if I'd quite say that.
You know,
but it's for someone who's you know, colds, flu, strep throat, sinus infection. You know, it can be stitches and lacerations,
or
and sutures,
it's
and
your daughter who doesn't feel well, and you know you don't deal well with that.
Right.
And so, you know, we think, you know, the advantage for us at urgent care. Again, because of the electronic medical record, and this is one of the pluses, you know, we've talked about some of the additional work required, but this is one of the pluses that, you know, if you're a Tri-County patient, you go to one of our urgent care sites, they just call up your medical record, they have all your history. They have your med list, they have your problem list, they have your family history, which is a wonderful thing if you're going into an urgent care site. So, you know, that's one particular project we have going on. Again, a new specialty, internal medicine / pediatrics, as well as urgent care. We're actually we have a developer that's building a building on Main Street for us, brand new facility for ear, nose, and throat. We are moving out of this location.
Phil, before you go on, the Hopkinton facility.
Sure, yeah, I'll go back.
I saw steel beams there.
Yes, yeah.
so it's moving.
Oh, yeah, we you know, originally we thought it was March, but you know that things always take a little longer than you expect, right?
So Phil negotiates so hard. So
Yeah.
it's,
That's right.
You let him off the hook.
I pushed it out too far, but right. But you know, then we go to it's probably June.
So it'll be this summer.
This summer, yeah. And
but the physicians that are going to run it are
already
here.
there.
They're just working in a temporary space.
yeah, right. So they're working that. We have another site in Hopkinton, a family medicine site. So they're really working out of that site.
So this can be like a reverse feed too, because when I asked you, okay, I need a new primary care
Yeah.
because my insurance has changed,
Yeah.
you immediately directed me there. I would have never thought to go to Hopkinton.
Yeah, yeah, and I was thrilled I was able to say that we have a doctor for you who's accepting new patients. So it's
Well, I was
good.
going to say that term, accepting new patients,
Yeah,
that's nice.
Yep.
Because, you know, you talk to friends around the country,
yeah, it's not.
and there are areas where they have to drive.
Yeah.
Because the very few, you know, it's back to the old 4 primary cares available and all 4 of them are full.
yeah.
Kind of nice that you still have room here.
Yeah, no. Well, you say what's the future? That's the future. We have to keep adding quality providers. But we have a new facility for ear, nose, and throat, which is going to be on Main Street in Milford. Do you remember where Robinson's floor covering
Yes.
used to be? Well, you know that building's been torn down. I think they have footings in place. And ear, nose, and throat, we're taking a good 7,000 square feet for our ear, nose, and
That's
throat.
pretty sizable
Yeah, it is.
space.
Yeah, we're also going to have, we recruited an ear, nose, and throat surgeon who also has a fellowship in facial plastics. So we're going to do some facial plastics. So we're going to have a piece of that building
And
devoted.
his name is?
Dr. Bill Recupero.
Who came on the
The
show
show.
and explained to us.
Yeah, good. Well, yes, good. That's right. He was on the show. Yeah, absolutely. So that, and I think we do hearing aids now, but really on a low profile basis. So I think we're going to do more with hearing aids. And again, being a Main Street location, it's a lot of visibility for hearing aids and facial plastics. So that is good. So, we have a lot of exciting stuff going on. We have a building. We just built a brand new facility in Northbridge, and I'm sure you've seen it? Have you been out there?
That's not in Milford, right?
Yeah.
Sure.
Okay. I forgot. Anything out of the Prospect Heights.
Yeah, I was gonna say, there's the center of the universe and there's the rest.
So we have a brand new facility that has, 5 family medicine docs and PT and lab, X-ray, but we're building another building adjacent to that for Whitensville Pediatrics, and we're providing additional space for another urgent care site. So hopefully in May or June, we're going to have urgent care in Whitensville as well. So that's very exciting. And we're hoping to do more urgent care. The plan would be to have a site in Milford for urgent care, have a site in Franklin for urgent care. So then you'd have Franklin, Milford, Hopkinton, and Whitensville, which I think
But now
would really
everything
serve.
I'm reading says that the insurance companies are frowning on these remote areas. How does that affect,
Yeah.
if they don't want to reimburse,
Right.
how do you do it?
Right. So for existing sites, it's not an issue. For new sites, for hospital-based services, it could be a problem. So you are going to see some contraction there if things stay as they are. So for hospital-based services, just nationally, you're going to see a contraction there. Or you're not going to see as many new sites.
No, that's
But for the professional service side, though, it's
For
still the
physicians,
same.
it
For the
doesn't.
physicians,
Oh, it doesn't
have-
affect
Doesn't
physicians.
affect the physicians.
Okay, because I kept reading that
Yeah.
they're trying to not allow you to build
Right.
that into
Right.
your costs.
Right.
Yes, right.
Right.
But what kind of services would be hospital services that they would classify?
Rehab, X-ray, could be lab, could be like a hospital surgery center, or cancer center, anything that you think of as hospital.
Thank God you built a building across the street
Right.
when you did.
Yep.
Yeah.
Well, that would qualify. It's close enough.
Oh, okay.
Yeah. Yeah, it's within 250 yards of a hospital.
Oh,
Yeah.
yeah, it's amazing how the care is dictated by the reimbursement.
Right.
But you don't have much of a choice.
Yeah.
You know?
But, again, urgent care is a nice focus for us. So again, those are the things we're trying to continue.
Well, that's wonderful, because if I go to the ER, or deductible copay, whatever you call it, it's $250, $500 out of my pocket.
Yeah.
I would assume this would be less by the insurance companies. because you don't have the overhead.
No, it'd be your typical copay when you go to your primary care office. Same copay for urgent care.
So instead of $250 to $500, I'm paying $25 to $30.
Right.
Sounds like a better deal to me.
Yeah, it's a much better deal.
How does this whole trend of evaluating teaching hospital reimbursement versus hospital reimbursement? Because everything we hear is if you go in town, and I go down on Binney Street and go to one of the big names, could cost me 50% more.
Yeah, so it's probably less about teaching and more about market clout. So they just, they have a higher cost base in terms of being more in an urban area. So they charge more. So it's really they negotiate more.
I could see if you've got to have the overhead of a Brigham and Women's or a man's greatest hospital.
Right.
At least that's what they told me they call it. It costs more.
Yep.
Okay, but if they're associated with a building out here, I kept reading that a lot of times they try and bill almost at the same rate for services out here that they do in town.
Right. Well, I think in healthcare, there's a tremendous amount of cross-subsidization. So I think from provider standpoints, that's kind of what they look at. But often the payers will really try to knock that down. So that's a negotiation that they have.
Because I could see that, to sit there and say, now wait a minute. If I'm going to a satellite center of MGH and it's in Milford, how is that any more expensive to run than your operation, our operation here? Because the Dana-Farber Center is right there.
Sure.
Right.
But that's not affecting us at all, or?
No. I mean, it could, in terms of exactly how Dana-Farber paid, we're not privileged to that. They rent space from us. They contract with the payers. But the payers in general are always looking at that. Even within a big system, they pay different levels for the tertiary center, the in-town, versus, again, we don't know exactly, but Newton Wellesley or Salem or there are other hospitals. So the payers are it's a back and forth negotiation.
But it's a pay negotiation with like a Brigham or a Mass General.
Yeah.
So it really doesn't affect the health care, the level of health care.
Right.
Correct.
It's just the accessibility could be affected.
Right.
So if I'm going into our Dana-Farber Center, I'm getting essentially the same level of care as if I drove all the way to Binney Street.
If we can do the service out here, there's certain types of specialty services that we can't do.
You just can't do.
Right.
What kind of percentage, when you think about of medical services, do we take care of 80, 90% of?
It's a high percentage. I don't, because it's their business, not ours. But in general, we hear pretty good feedback from our patients. And the thing that really is great about this connection is, and I've heard this from a lot of our employees that unfortunately have had to go across the street, and they say, they'll just pick up the phone, they'll look at, they'll call Boston, they'll look at their records, and it could be to call, with technology now, but that connection to Boston, or sometimes they'll say, geez, I want you to go see this sort of super specialist in Boston, and then they end up back here. So that, that continuity is really, really terrific. And then sometimes it's age, sometimes it's a special, procedure that they'll need to go into Boston.
Well, I mean,
but it's
people that fly from the Middle East to go to Children's for very, esoteric indications. Sure. Yes, you're not going to be able to support.
Yeah, I mean, there are the super specialists. I mean, there are things we don't do, and you need those super specialists, Al. So, I mean, when some people go.
But we have access to them, which.
Right. Well, that we have access to them, right.
When we think of the medical center, how many people are actually employed between the two of you?
Over 2,000.
Over 2,000.
Over
yeah.
2,000.
Is there anybody even close to that number as an employer?
In the town of Milford?
In the Milford area?
Yeah, I think Waters is.
Waters would be one.
Waters would be one, yeah. That's the only other number.
But that's about it. I mean,
Yeah.
realistically, if you look in the area, you got an EMC, or Dell, or Waters.
Yeah.
But your organization employs as many as everybody.
Yep.
Yeah.
And then I look at the ancillary. You know, I mean, there's medical buildings popping up everywhere, or medical service buildings.
Yes, yes. We're doing a lot of construction lately. That kind of has a ripple effect everywhere. So that's true. Yes, no, in terms of an economic engine, you know, we are significant with 2,000 employees, and we're always doing something. So, yeah, I had someone stop me the other day, said, geez, you know, you really have a lot of activity going on. I said, yeah, we have buildings in Hopkinton, we have buildings in Whitensville, we have a building on Main Street in Milford, we had just finished new construction. So, yeah, so that's, yeah, we are, I think, a significant economic engine.
So now you're giving Martin, the fundraiser, the third leg of, you know, the medical center. Now that he's raised $25 million, does he get a day off, or?
We gave him a couple days off, but that's it. He's still busy. There's always things going on at the hospital.
Well, I think it's important for people to understand that you have a little bit of a sprint, you know, a $50 million sprint, if you call that little.
Right.
But day to day, we still count on people's donations.
We do.
Yeah.
You know, you're talking about donations, and I didn't say this earlier. I want to say it, but we talk about the me and family and how special they've been, and Kevin and Patty donated $5 million, tremendous. But Kevin Meehan, the story behind the story is 5 years ago, when we were starting to think about what's our next project, and you know, it was like ED and ICU and the 4-bed rooms. And Frank and Phil and I said, so which one are we going to do next? And when we talked to Kevin, Kevin's like, you got to think bigger. You know, the reputation of the community is going up. You're recruiting all these physicians. Don't sell yourself short. He said, you got to do them all. And you know, Phil and I are financial people, and we're sort of saying, well, that sounds good, but you know, where's that?
Where's
you
it
know,
coming
where's it
from?
gonna come
Yeah,
from?
like on the FinCom, we say, great idea, how you paying for it?
Right.
And so, but Kevin said, you know, you've got to tell your story. You've got to go out. And so again, the building is beautiful. Their donation is tremendous. But really, the big story behind the story is that he went out and really said, you got to do them all. And we said, this is going to cost over $50 million. And, you know, we were sort of like, are we talking reality here? And he said, yeah, you got to raise half of that. It's not going to be easy. He said, but you got to do it. And so he pushed us. And you know, he's a fun person to work with because he's just thinking 5 steps ahead of you. I mean, he's thinking about the grading, the landscaping, where the building's going to go. He's thinking about how you're going to add on to it in the future. I mean, he's way ahead of us. You know, we're trying to say, you know, are people going to laugh at us? And so that, you know, that it's constantly moving in terms of, you know, we've committed on the next couple of years for our events towards that fundraising. So back to Martin, we still have our you know, lots to do in terms of, you know, we finished golf and we're on to Melange and year end and events and the annual meetings. So their plate is pretty full. But
You know, I wanted people to understand though that every year, you really do count on
yes,
the donations
yeah.
to do those extra things.
Right.
Yeah.
Yeah. And our big events for the next 2 years are counted in that $25 million.
Yeah, yeah.
So we're assuming the continued good job that we've done.
Yeah.
But you know, you think about it, you know, you think of the Oliva Fund.
Yep.
How many families, you know, when you're under the stress, you're under all of the pressure, to eliminate a little bit of the financial problem, you know, that they do, to do all the little things. I'm really impressed with, you know, Carla, Jean, you know, everybody down there, what they do with the Oliva Fund to help out
Right. Yeah.
our
Yeah.
residents.
And that's helped to support cancer services at the hospital. You know, palliative care, any, you know, cancer things that we need at the hospital. It's been really, you know, outstanding. And you know, Dana-Farber has their Jimmy Fund, but you know, Milford Regional has the Oliva Fund. So
Yeah.
it's
Yeah, no, that's right. And you know, just to continue with that point, Al, I mean, you don't have to be a huge organization to help out, you know, because every little bit helps, you know, everyone giving $100. And it matters because, you know, healthcare is just a very tough business environment. You have, and we were talking about it earlier, you have the insurance companies and the government, Medicare, Mass Health, they're really setting your revenue. So they're saying, okay, for this procedure, for this visit, this is what you get, for this stay in the hospital. So it's not like, you're in private business and you say, okay, my cost is
I'm going to
this.
raise my price.
I need my price to be this because I need a margin of this to continue. So, you always have, so that makes it very difficult. So, you have to be very efficient. You have to either do volume or be very
Phil,
efficient.
you mentioned the $100. But that $100, if that helps a family financially pay for dinner, do whatever they needed, that's one less thing they have to worry about.
Right.
Because if they have somebody at the medical center, you hate to say it, but I hope Mona runs out of customers.
Right.
Yeah.
Right? When you think about it, I'd like to have every oncologist out of business.
Right.
Yeah,
Because they
that's
don't
right.
have any business.
That's right.
But you don't see that happening in our lifetime.
Right.
So if they're taking all the time off from work, a lot of times that $100 could make or break that week.
Right.
Yeah.
That little bit extra that the Oliva Fund does.
Yeah, no, it's very, very important. And it really, I think it symbolizes the type of community that we are, that you have a family that's really taken upon himself to generate all this, revenue in donations for cancer services at the hospital. And it's a
Think
neat,
about it. You talked about the consigli floor.
Yeah.
Another family.
Yeah.
That,
Yeah, very.
Hey, Anthony, we got a problem with St. Mary's Church.
Yeah.
Next thing you know is he's got a crew down there looking it over.
Yeah.
Yeah.
And now all of a sudden he's helping. And
Yeah.
I think a lot of people forget how important these contributions are.
Yeah.
Yeah.
If Kevin Meehan hadn't given $5 million, it would have been hard to raise that money.
Right.
Yeah, that's certainly helped. Yeah, and to your point, the consiglis have been very generous as well.
And there's a whole series of
They're
families.
pretty good at construction. So.
Yeah. Yeah, they got this little tiny construction company
Yes.
down the other end of town.
Yep.
But again, it's a sense of pride.
Yeah.
Yeah.
You feel good that not only a Milford family's done well, but that they kick back to help
Right.
Yeah.
everybody in Milford.
Yeah. Exactly. Al, I wanted to mention a couple. You talked about what's going on at the hospital. We want to do at the hospital what's a good basic service. A few years ago, bariatric surgery wasn't something that was necessarily, the best thing to do at a community hospital. So you know what? We didn't do it. But over the last number of years now, as it's become a safer surgery, there's different types of bariatric surgery, and probably the most popular now is the sleeve surgery, which is like half the surgery. And we've got terrific surgeons that come from UMass that, you get the same surgeons that can do it at Milford that do it at UMass. And again, the sensitivity on the copays and deductibles make a big difference. But more importantly, the outcomes is really, really terrific. So that's something that we see growing at Milford over the future. In fact, and I couldn't explain the details, but sometimes robotically there's advantages to using the robot towards bariatric services. And then another, when we built the new building, in the new ICUs, we couldn't do everything. So some of it is just kind of capturing our breath and growing into the building. But we've made provisions. We wired the building for what's considered EICU, so electronic EICU. So we're so lucky. In Phil's group, we have 6 critical care pulmonary physicians, which, a lot of community hospitals, if they have 1 or 2. But
I was going to say, if you got one, you're happy.
So
we're lucky to have them. And we have residents in the hospital 24/7. We have hospitalists. But this is like the final layer on top of that, where shortly we're going to be our sort of electronics in the room monitoring ICU patients are going to be in this bunker at UMass, and so whatever we want in terms of time of day, but there's going to be a camera where a physician can see the patient, and families and patients can see the doctor. And they're part of our medical staff. They can give direction. So it's that extra layer. So again, there's no rest for the weary, as we
But
say
again,
in Milford.
when you think about one of the things that, at least I believe, has really kick-started our medical center was that collaboration with UMass.
Yep.
Yeah.
Boy, you guys get the inside track. Out of those 6 that are 3,
Yeah.
if 1 or 2 have done their internship here, Phil gets to hook them
Yes.
Right.
Yes.
and do his sales pitch before those other.
And we look to do that. We look to do that. Yeah.
Actually, a lot of times they come, it used to be they'd come to us.
Yeah.
They'd say, well, we love it here. Are there any jobs?
Yeah, it's
a little harder now.
A little harder now when you're looking at 6, but nonetheless, yeah, we're very lucky too. I mean, we, in terms of dealing with tertiary centers, UMass on one side, and Brigham and Mass General, and particularly Brigham on the other side. Dana-Farber on campus.
Yeah, but
children's
really good
children's
at
on
picking up
campus.
people who are tied to this area. That's got to help with your longevity, because I know you look, they were from Milford, or they have family.
But recruiting, it's funny. Years ago I used to get these CVs from San Antonio, Texas. I spent a weekend in New England. I liked it. And I used to waste time. You'd call them, you'd talk to the recruiter, you say, hey, maybe we'll pay for transportation. Now we look at a CV, for a physician, it's got to be local. There got to be some local route, so because you want them to stay here.
Right.
So you recruit based on that.
You don't want somebody for 3 years.
And-
I mean, not just the training and all, but again, from a patient point of view.
Right.
And I think my mother has been more than a decade, has gone to the same Dr. Mona.
Yes.
And it makes her, she's 93 years old. She
Mona's that old? No, I'm sorry.
Mona watches this.
Can you edit this? Can you edit this?
Yeah, I was dead on that one. But,
I love motorcaders, you know that. Yeah.
but the whole crowd that is there, it goes back to the fundamental roots of the 4 physicians who brought in most of Milford.
Yeah.
Yeah.
By the way, your mother looks great. She really does.
Yeah.
I think Phil made a point at the beginning that people don't realize is that we really are one system. Effectively, to the outside world, we really are one system consolidated. And I think one of the things in this transition with Frank leaving is that Phil and I have worked really hard to kind of promote and even kind of reconnect in a tighter way. And for me, a big part of my transition was taking over responsibility for Tri-County. That was the difference between Frank and I. And so I want to just thank Phil, and again, us working together is
Well,
going
the
to be...
other thing, too, in
No,
today's
I was
day
gonna
and
say
age,
something
when we look at the efficiency of people who collect money,
Yeah.
I mean, I'm impressed that you don't see your organization under Martin giving 20% or 40% of the money that we donate to the medical needs. There is not much overhead there.
It's direct.
It's not like these people who call them collecting for the police or the firemen, and 15% of the money you give goes to them.
Yeah.
But I just want to make one point as well. We will all miss Frank, and Frank was a terrific leader. But I'm very excited about the opportunity to working together with Ed, and we're very excited about really doing some great things in the future. So I just wanted to really make that point.
We thank you for everything you've done. I mean, when Frank came on, he talked about the young Ed Kelly coming on as the new CFO and how much you've contributed, and we do look forward to the new vision from the not-so-young CFO that now knows us dead cold.
No.
And as always, I've said the medical center here is probably the biggest gem we have. It's amazing the effect it has on families when they can get the highest level of quality care in our own home. So to the 2 of you who have had so much to do with taking care of our families, thank you. And to our 6 loyal viewers, and hopefully not Mona Kadis, because you'll be in trouble if she's watching.
I got damage control.
And your ratings haven't gone up. You were 6 a couple of years ago. Aren't you up to 8 by now?
You're up to 8. May God bless, good night, and may tomorrow be a healthier day than tonight. Thank you.
Thank you for having us, Al.
Not too long since I've been home. Been running all my life just searching for my soul.